Welcome to episode 133 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And we want to welcome back special guest, Dr. John Lynn. And Dr. Lynn is a solo practitioner in Gilbert, Arizona. And we wanted to talk with John today about telehealth and how he's using telehealth and cover just some basics of overall telehealth as well. So welcome, John, and thank you so much for joining us. Do you want to share a little bit about the Thriving Urology Practice Facebook group and how people can join that, as well as anything else you'd like to add?
Well, thank you so much to everyone. Thanks for everyone for tuning in. The Thriving Urology Practice is a free Facebook group that I created several years ago to specifically help urologists and urology practice folks, including the C-suite people, medical assistants, advanced practice providers, urologists, coders, billers, where anything goes, anything that we can do to discuss to advance the field of urology, practice management, coding, billing, anything and everything is discussed there, including sometimes you share jokes and memes that are not appropriate for work, but we do share those in the Thriving Urology Practice Facebook group. And as I like to say, if it's free, I'll take 3. And Scott, what do you say?
It's for me.
If it's free, it's for me. Yeah, so I like sharing knowledge, and I think a passage from I don't generally like to go biblical, but if you look at Philippians 2, chapter 2, verse 4, let each of you look not only to his own interests, but also to the interests of others. And I think of you guys, the painters, when I read that phrase, because you are constantly helping urology practice, and urologists to advance our practices so we can do better. And it is with that mindset that I created that group, and also that's pretty much what I do now to help. Not just the verse says, "Look, let each of you look not only to his own interests." So you're not just looking out for others always, but you're also looking out for your own interests, but also to the interests of others. And I feel like that's what the painters do it seems like every single day. You're constantly putting out content that helps urologists. So for that, I'm extremely grateful, and I'm super grateful to be on this podcast once again.
Thank you, John. That's very kind. Well, we're excited to have you and excited to dive into the topic. Mark, Ray, do you want to add anything to before we get started?
So the only thing I'm going to add is that everybody knows by now that we've got an extension of the public health emergency telehealth rules to the end of 2024. And we're pretty certain that Congress will fix the Medicare program long term. So one of the reasons I think we really wanted to have John in to talk about telehealth is it's time to actually start leveraging this tool in urology across the board. It is a time saver and a moneymaker, and it also really actually is loved by your patients. So use it wisely and really start leveraging it as another tool within the chest to help treat your patients.
So Mark's been talking about telemedicine for seems like forever. I remember attending the Urology Advanced Coding and Reimbursement Seminar. Oh gosh, that was December 2019. And I started taking down notes again whenever Mark was talking about telemedicine. And I actually started looking into different platforms at the beginning of 2020. Little did I know, on March 19th of 2020, I would start and use my first telemedicine visit. And now I'm over 4,000 encounters in, and every day that I'm seeing patients, I'm using telemedicine. It is definitely, well, as a consumer, as not just a provider of healthcare, as a consumer of healthcare, I definitely appreciate it when I could use telemedicine instead of having to leave my office, stop work, drive somewhere, find parking, find out where the office is, and then getting that care. And I know my patients love it as well. The ship has sailed. Telemedicine is pervasive. Your patients want it, and those of us who have done it love it. So hopefully, this is kind of like the overview, but I hope to get into the nitty-gritty of not just the why, but also the how.
Ray, any thoughts?
Yes, the telephone has always been a very important part of our practice. As many of you know, I started my practice back before video was a big deal, but the telephone was still a big part of the practice. And I was excited when there was a way that came about that we could use the offsite communication to really communicate with our patients. I practiced in rural Colorado, and I serviced a large area, and there were a lot of little towns around us. And back in those days, I started clinics in all of those different areas for at least one day a month, so I could meet the patients kind of where they were. And if I'd had video conferencing, I wouldn't have had to have done all that travel. So I'm excited to see this grow and more urologists take advantage of it. And as a patient, I can tell you, we appreciate it when you make that effort.
Absolutely. All right, John. Let's hear how you're using it and kind of what your thoughts are and your best practices.
All right, so let's talk about, obviously, we can't skip over the coding aspect of telemedicine. And what Ray said, the telephone-only visits, that's available. Today, I'm going to concentrate on not hospital-based, not facility-based telemedicine, but more clinic-based telemedicine. So for the telephone evaluation management service, there's the 99441, 442, and 443. It's not just you picking up the phone and talking to the patient. I don't generally do that for many reasons, but you have to keep in mind if you're using telephone only, that it has to be with an established patient, parent, or guardian, not originating from a related evaluation and management service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. So it's not just you picking up the phone and you want to get on. You have to follow the established, published rules and apply them when you are doing just telephone only. So as Mark mentioned, the telemedicine flexibilities have been extended until the end of 2024. So let's quickly go over the timelines. The Omnibus bill extended some of the telemedicine flexibility for 2 years, and that was an early Christmas present given to us on December 23rd of 2022. And then this month, we received from Secretary of Health and Human Services, Xavier Becerra, that the public health emergency flexibilities are ending. That means on May 11th of this year, the public health emergency will be ending. No more 1135 waivers. That means you have to use a HIPAA secure BAA Business Associates Agreement covered video and audio platform. And then in October 2023, the 151-day extension ends as per the Consolidated Appropriations Act in 2022. The omnibus flexibilities remain in effect. For instance, payment for audio only, no originating or geographical site restrictions, no in-person requirements for behavioral health. Those are extended. Very small impacts to telemedicine, but keep an eye on virtual supervision rule changes. And then in December 2023, inpatient telemedicine codes may expire, so stay tuned for that. In January 2024, CMS calendar year 2024 telehealth codes will begin. And in December, the omnibus flexibilities and CMS calendar year 2024 flexibilities will end. And then in January 2025, the newer telehealth codes will begin. And hopefully Congress will have acted and make some of these changes, especially the payments, permanent. So there's a huge demand. The payment is there now, thanks to the flexibility. And to quote Rahm Emanuel, right? He said, "You never let a serious crisis go to waste." And I think the serious crisis, we're pretty much over it. We definitely did not let it go to waste. Congress did not let it go to waste. Medicare did not let it go to waste. And the patients are definitely benefiting from the availability of telemedicine. So the payment is there, not just CMS, but also private payers. It is now being paid. It has been paid by the payers and CMS. And the telemedicine visits are on par as far as payment goes as an established or new 9920X or 9921X billing level. So there's payment parity among the payers among different states. The patients demand it, and it is being covered, and it is now legit to do it, legal. In the past, you had all sorts of restrictions where you can or cannot provide the service, the technology that you needed, but the pandemic kind of led to a lot of relaxation of these rules and policies. So definitely get into it. Mark, would you mind covering the place of service code changes in 2023 as far as telemedicine goes?
So sure, John. So there's a couple of things that we're still, I think, going to wait for as to what we're going to see with place of service. We have a place of service 02, which is when a patient is in a Medicare approved facility when they receive telehealth, and there's place of service 10, which is when the place of service where the patient is at home receiving telehealth. And then, of course, you've got place of service 11, which is your office. And during the pandemic, they allowed the use, the health emergency, they allowed the use of place of service 11 because that allowed for payment parity. That the way the program was set originally is that place of service 02, which was the only one allowed prior to the pandemic, that actually paid the facility-based payment. So we're going to have to keep an eye on when Medicare, or if Medicare is going to make that switch to 10 as a requirement if the place of service is home. So we'll have to keep an eye on those regs if they're going to pop over to switching to place of service 10. I will tell you, John, that there are some of our private payers in some states that are switching over to place of service 10 and paying lower rates. And that is going to be governed by states as to whether or not there is a requirement for telehealth parity in that particular state. So some of your commercial payers may be making that switch to place of service 10, but you certainly want to keep an eye on that until right after the public health emergency ends. That may be something that state by state, some of your commercial plans are going to be making some switches in how they pay. And we've already started seeing that move for some of your payers. So keep an eye on your payers and their bulletins, and then we'll sort through how Medicare is going to phase this longer term as far as the requirement of place of service 10.
It sounds like what you're saying is that the modifier code may or the place of service code may change, and
Right.
if you start using 2 or 10, reimbursement may be at the facility rate versus right now what I'm using, place of service 11, it is paid at a non-facility rate, which is higher than the facility rate.
That is correct. And so you want to keep using 11 as long as you can. Unless we see place service 10, see payment parity within Medicare.
There you go. Gold nugget right there. And I know we're concentrating on the synchronized audio and video visits today, but there is something that you may need to add for telephone only visits. Boy, I need to. Yeah, go ahead.
Yeah. So with the telephone only visits, you've got a couple of things that are there. I mean, the payment parity is there. The 994, 41, 42, and 43 pay exactly the same as the office-based 992, 12, 13, and 14. So the actual reimbursement level is the same. The issue, unfortunately, with telephone only visits is that you can't use medical decision making. You can only use time, and you can only use time on the phone with the patient. So you need to make sure that you are documenting well that time spent on the phone with the patient. And from a practice flow perspective, you still want to be able to document, obviously your clinical decision making with your MDM that's there, because you do have some of your private payers that are actually using E&M visits with modifier 93 instead of the 994 codes to allow you to get reimbursed as if it were an E&M visit, but it was phone only. Medicare did not make that move, but some of your private payers have. So if you look at it from a documentation standpoint, I always recommend that you go ahead and build your visit as if it's E&M, and then add that time on the phone so that you can adapt to each of the payer rules, whether it's phone only or E&M.
So it sounds like modifier 93 for telephone only visits, and if you're just doing audio only telephone visit, then you are basically counting or billing based on time, which in my opinion is much less efficient when it comes to productivity.
Mine too.
All right. So when it comes to synchronized audio and video, your practice overhead is probably going to be slightly lower. As we mentioned, it saves patients on travel, having to find a sitter, the wear and tear on a vehicle, and heck, one of the riskiest things that we do every single day is to take on the road, to drive on the road. All that is eliminated when telemedicine is being used. Unless, of course, you're one of these patients who tries to conduct a telemedicine visit while you're driving your 18-wheeler or while you're driving your vehicle. Then I question, what is the proper place of service code for that particular visit? No, seriously though, whenever I notice that a patient is in a vehicle, I make sure that he or she is not driving, and I make the patient pull over off the road before I begin the telemedicine visit, just to be on the safe side. All right. In addition, when you are doing telemedicine correctly, the patients feel like you are paying more attention to him or her. And web ticket or net ticket is really important. For in-person visits, often the practitioner, the qualified health professional, is having a computer or a notebook computer between the patient and the provider. Or worse yet, you have the computer mounted to a wall and you're facing the wall and not facing the patient. When it comes to telemedicine, you're looking at a camera, you're facing a camera when you're providing that service. So for some patients, they feel like I'm getting more attention from the doctor. So that's another positive thing. Another positive is that now with telemedicine, I can include family members. For instance, I may have just recently diagnosed this gentleman with prostate cancer. He wants to include family members from different parts of the country or different parts of the world in that visit. I now have the ability to do that with telemedicine. If you need a translator, it is very easy to include that translator in that telemedicine visit. I've used that numerous times as well. And the other advantage of telemedicine is that it seems like these visits are much more succinct, much more focused than in-person visits. Patients know that we are here to talk about the disease process. The visit seems to go a lot smoother, a lot quicker in my telemedicine visits. And that's my limited experience with over 4,000 telemedicine visits. Your mileage may vary. Any comments?
Ultimately, I do think that having those telemed visits, because there's a little more focus there, tend to be shorter, from what I've seen, which is also helpful. And actually, another place that I see this as a major advantage is for groups that maybe are space challenged, if you will, that, you're trying to stagger what docs are in the office when, but, not having to use multiple rooms is a huge advantage.
Yeah, some practices productivity is limited because they don't have the space to accommodate all the providers, all the qualified health professionals seeing quote unquote patients. And if you use telemedicine, heck, the qualified health professional can be anywhere. But in my case, I set up a quote unquote studio in my office where I go to provide these telemedicine services. You don't have to do that. You can actually provide the service anywhere that you have internet access, solid internet access. So let's go over patient selection when it comes to telemedicine. The reality is you can see telemedicine patients whether they're established or new. So synchronized audio and video. That's what I'm talking about today. New or established patients are allowed. You can see them both. But for me, I limit my telemedicine visits to established patients only. It affords a lot more control over the flow of the visit, how long the visits are going to last, and it just makes it a lot more efficient. I'm not having to get to know the patient because I already met the patient. I've already physically examined the patient. We already established a plan of care. So I limit my telemedicine visits to established patients only, which allows a lot more better management of the duration of that visit. I understand that if patients are in a rural setting, then obviously you may want to consider seeing them as new patients because of travel restrictions and things like that. One of the limitations of being in that rural setting is that high-speed internet connection may not be there. And they may not have 4G or 5G, or maybe they may not have access to Starlink for that fast internet access for synchronized audio and video. So in my practice, I try to see established patients, and very rarely, extremely rarely will I see new patients as telemedicine visits. Interestingly, one observation that I found is that there are fewer no-shows when it comes to telemedicine. And often I'm running ahead of schedule when it comes to telemedicine. Now, in real life, if you're seeing patients in person in the office, you now have to rely on staff to call that next two patients in earlier. When it comes to telemedicine, I have the EHR open on one screen. I have the telemedicine platform on another screen. I can text message the upcoming patients to have them show up early if I'm running ahead. And that's another positive of doing synchronized audio and video telemedicine visits. It's very easy because they're already planning to engage you on an electronic platform. They're close to their phone. They're close to their computer. If you text message them, they can hop on right away. And just don't think telemedicine is just the patient looking at your face. I have the ability to show any lab, any pathology, any imaging I can show on the screen. I have the ability to share that with the patient. In addition, if they want a copy of the CT report, if they want a copy of the image, heck, they can screenshot it, number one. And number two, I have the ability through the platform that I use to securely transfer these bits of data, these sheets of paper, if you will, electronic paper, via PDF, securely through the platform to the patient, so they feel empowered. The patients are empowered with information and with knowledge, because often you can say X, Y, or Z, but they may remember A, B, and C. If they have that piece of PDF document that they can refer back to, then it's an advantage to empower that patient. Any comments?
I think that's really powerful. I think, having and empowering the patients and having that visit. If anybody out there is listening and hasn't really embraced telehealth, I think you've heard a number of reasons. why, just from a patient care standpoint, why it's a very valuable tool in your toolbox.
All right, so let's get into the weeds a little bit. Let's talk about tech briefly. Stop using FaceTime. Stop using non-HIPAA compliant platforms. There are free platforms out there for you to use. The 1135 waivers are going away on May 11th of 2023. So there are free platforms out there that are super easy for the patients to use. No app to download. If they know how to use a browser, and every smartphone comes with a browser or two or three if you download an additional browser. So those are the only things that the patients need. There's no app that they need to download. And the way I think of it is I want to make it as easy as possible for the patient to engage with me on a platform. In addition, for those of you who are on the more administrative and management side of things, you want to make it as easy for the provider to get on the telemedicine platform as possible. So there's no additional app to download. I use doxy.me, doxy.me. I'll phonetically spell it. Delta Oscar X-ray Yankee period Mike Echo, doxy.me. It's free. Some people use Doximity. I believe that is also low cost or maybe freemium. You can upgrade to a higher level of higher tier to get better, more capabilities. And I purchased a fairly low tier plan on Doxy as well, but you can start out free. So again, if it's free, I'll take 3. So the other thing about technology is that whenever you are appearing in front of a camera, in front of a telemedicine camera, you want to consider using a wired connection and not Wi-Fi, because Wi-Fi is a little bit less reliable. So from my perspective, I want to use a wired connection. In addition, audio means a lot more than the quality of the video image. So use an external microphone whenever possible. If you have a cell phone headset, use that. It's better than the microphone that you have on your cell phone. So external microphone, wired connection, use a HIPAA compliant platform. And also video presence. Now, I talked about webetiquette or netiquette. Your online presence, your video presence, make sure the lighting is in front of your face, not behind your head. Make sure the camera is positioned at eye level. Nobody wants to see the bottom of your nose or nostrils, or nasal opening. You don't want to put the camera below you. You want to put it at eye level. And make sure you're looking at the camera. That is how you make contact with the audience, with your patient. Look at the camera. It's awkward. You feel like you want to look at the patient's face, which appears on a screen, but you're not connecting with the patient when you're looking at the screen. The patient sees you through that camera, and that's something that you want to practice. It's awkward initially, but then it becomes second nature. Consider the environment in which you're conducting the telemedicine visit. I'm in a sound-treated room that is blocked off. I don't have the sound blasting from speakers. I'm using in-ear monitors or headphones. So I'm really mindful of patients' privacy and security of their information. Consider using a dedicated office space or dedicated space. Consider using headsets so patients not sharing information that anyone can overhear. Privacy, very important. Just because you're doing telemedicine doesn't mean that you can just wear whatever you want in your pajamas. This is still a professional interaction. Consider your attire. Consider acting and behaving and using body gestures, body language in a professional manner. And communication is, as many of you know, is mostly through body language. Only 7% of communication involves the words that we use, even though we perseverate and fixate on the words that we choose when we communicate. But most of communication, when people can see you, is through visual means and also tonality, the up and down, the pauses, the volume of your words. That's another huge part of communication. Audio matters more than the video quality, the image quality. That's something else to consider. Any comments from anybody?
agree, John. I mean, it is pay attention to all of those items as you get through. You want to, in essence, what we're saying is it's time to get serious about telehealth and its delivery. And one of the pieces you need to do is consider how you're going to do it. What's your tools? Where's your space? All those are important.
All right, so let's get into, this is the key thing right here. This is what makes my life super, super easy, other than picking a super easy platform to use. Preparation, and I hate to say this word again, clinical workflow. Workflow. Everybody's talking about workflow. So the preparation, the clinical workflow optimization, this is key. You want to make it seamless for the patients and the physicians. So you want to prepare this visit like it's an in-person visit. This is imperative. What that means for me is my amazing medical assistants, they do the tech check. They make sure that the patients know to enable their camera, enable their microphone when they click on the website link. My medical assistants make sure that all the documents are in the chart, just like an in-person visit. For instance, if they're following up with the PSA, I want to make sure that the MA has already checked to ensure that the PSA results are already in the chart. If I'm going over pathology reports, I want to make sure that's in the chart. If I'm going over imaging, I want to make sure the report is in the chart. So make sure that is all done, just like an in-person visit. My medical assistant also documents the chief complaint, the reason for visit, the patient words, if you will. She updates the past medical surgical history. She ensures that the patient is in the state in which I'm licensed to practice. This is really important. Because you're doing telemedicine, you don't know where the patient is. If the patient is not in the state in which you're licensed to practice, and also in addition, where you have medical malpractice insurance, then you are literally practicing medicine without a license if the patient is out of state. So that's really important. My medical assistants make sure that is happening. She lets the patient know that this is a billable procedure, and then she collects the copay, unmet deductible, coinsurance, balance due by capturing the credit card information, and then she will bill out that visit. She will ask if the patient wants a receipt, and we will transmit that to the patient if that's what they want. So all that is done before I see the patient. In my EHR, this verbiage appears after the chart prep is done. This encounter was completed via HIPAA-compliant two-way synchronous audio and video communication platform. Patient's identity was confirmed, and patient was in Arizona, where I'm licensed to practice. Verbal informed consent from the patient to proceed with the virtual visit was obtained. Patient voice understanding regarding benefits, risks, alternatives, and option to not participate, and that it's a billable encounter. Patient desire to proceed with the telemedicine visit. So that verbiage is included with every single telemedicine visit when I provide that service. I typically review the chart prior to starting the encounter so that when I appear, just like in-person visits, I look at the chart before I walk in a room. So this is not a complete blank slate. I have context regarding why the patient's being seen today. And then I start the visit. The patients are informed to check in about 5 to 10 minutes prior to the visit appointment. That's something that my MA does. And then my staff, I call it chunk the visits. They chunk the visits, which means I'm seeing a bunch of telemedicine visits at the end of the morning or at the end of the day, and they're all together. And I think that is a much more efficient way to see patients than to see them between patients. That is, it's too jagged, if you will. The flow, the clinic flow is too jagged. If I have to run to the telemedicine room and then run to the procedure room, run back to the telemedicine room, and then run back to an exam room, I think it's a lot more efficient if you sit down once and go over telemedicine one after another. So that's my impression. And I'm going to have two more subtopics to discuss, and then we'll be done. Thanks for your patience. Go ahead, Mark, Scott, and Ray, if you have any thing to add to color.
I got a question for you on the on your MA setup. So you say your MA does all the prep work, and does your Doxy.me do a good job of handing that over, or how's that done? Is your MA set up in a totally different area and has her own, or
Excellent
is it her
question.
own setup? I think you said
Excellent
her.
question. She actually gets on the phone with the patient to gather a lot of the history. She does have a computer in front of her, and if she wants to check to make sure that the patient is actually able to get on, she sends the link to the patient. The patient clicks on the link. It then asks, do you want to enable microphone and camera? The MA says, hey, check yes on those. She can pull up my Doxy.me platform and look and make sure that the patient appears on camera. She can hear the patient, and that's all that tech check that's needed. She doesn't even have a camera on her computer. She just needs to make sure that the patient is visible, and if that is set up, then by the time he or she logs in the next time, when I see the patient, because the patient's not going to stay on the whole time, because my MA is checking and prepping the chart about usually the same day and sometimes the day before the visit.
All right.
So during the visit, you want to tell the patients that, hey, sometimes I'm looking at my electronic health records, I'm looking at your chart when I'm looking away from the camera. Active listening is really important. You want to read back what the patient is telling you to confirm, just like in-person visits, right? The read back, and also shared decision-making, just like in-person visits. When I see the patient, I have the Doxy.me platform on what's called a teleprompter. Teleprompter is a screen that projects an image on a piece of glass, and behind the glass is my camera. So when I'm looking at the patient, I'm actually looking at the camera. So you don't have to do that. That's next level stuff. This just simply allows me to engage with the patient. I want to make sure the patient has the best experience possible, because these patients can leave you a review just like a real in-person visit, right? You want to make sure that they have the best experience possible. And that's why I use the teleprompter. I'm looking at the screen that displays their image, and actually that image, behind the image is my camera, and patients feel like when I'm looking at them, I'm looking at the camera. They feel like I'm actually looking at them as if it's in real life. Sometimes better than in real life, because you're not distracted by a computer. All right, so when it comes to documentation, I document in the EHR during and immediately after the visit. Just like in-person visits, I close the chart the day that I see the patient. In addition, any correspondence with the referring doctor that is sent to the referring doctor the day that I see the patient without fail, just like in-person visit. And then you might be thinking, okay, great, you saw the patient. Now the patient needs imaging or be scheduled for surgery. Well, my staff will follow up on the plan of care after I close the chart. Any labs, surgery, scheduling, biopsy, imaging orders, that is all done on the back end by the staff. So this is, even though you may save on a physical space when it comes to telemedicine visits, this is still not a cheap visit, if you will. It still requires a lot of resources, but it is just a lot more convenient for the patient and a lot more convenient for the physician or the APP to deliver that care. And you want to document the day of the service, the time of service. It is most likely mandated by your state. It is definitely mandated by Medicare. You want to close the encounter. You want to bill at the time of it, or the same day or the next day, as soon as possible, to decrease or shorten your revenue cycle. And that is pretty much it for my telemedicine spiel, and I hope I deliver some good nuggets.
Excellent. Hey, John, one other thing that I've seen that's out there is, and you obviously need to take into account the privacy there, but leveraging your MAs. I've got a few groups that are actually, because it's virtual, right? You don't actually need your MAs in the office to get everybody set up and running. And so we've seen a couple of different groups that have used the setup of telehealth and their MAs to give them a little bit of time away from the office. And it's worked really well. So that would be the other thing I would add into the mix, that you do have some flexibility in where your staff is going to be located to do that follow up, and that may be another thing to add into the mix.
Yes, virtual assistants, definitely in the play for now. And one of the easiest ways to decrease that physician burnout, because unfortunately medicine, and for most of us who participate in third-party payer games, it is a game. Third-party payer games, we have to comply with documentation requirements. And one of the 1,000 jabs of death to leading physicians to burnout are the documentation requirements. And the easy ways to overcome that are to use voice recognition, Nuance's Dragon, which is what I use, or a virtual assistant, or an in-person assistant, a real-life assistant to help with documentation. I know urologists who have used virtual scribes. They literally take a computer in a room with a scribe somewhere that is listening in on encounter and making the documentation on behalf of the physician, and the urologist simply closes the encounter after he or she verifies the accuracy of that documentation by somebody else. So that burden of documentation is lifted with a virtual scribe. And you can carry that out, like Mark said, by using a virtual medical assistant to capture that history, and the assistant, if he or she is off-site, depending on the situation, that may or may not work for you. That person may be off-site and be able to provide that virtual care, which is a synchronized audio and video experience to the patient, and it could be fairly seamless.
You just got to make sure that that's all HIPAA compliant from your assistants as well.
Even that is not as common, right? The virtual assistant thing is not as common, but the entities that provide these services for virtual assistants, they almost always use a headset, so you're not exposing protected health information to other people. Where I see a lot of egregious offenses are among billers and coders who work off-site. Do they have a protected space that they have all the EOBs strewn out? Do they lock their computers when they go away? Is that computer dedicated to the work that they're doing? So I digress.
All right. Ray, any comments?
Well, yes. As all of you know, knowledge is power. And you've heard the details of setting up and using telemedicine from an expert. John, I've been impressed with, as he's worked with us our seminar, as being someone that's extremely knowledgeable about the technology and a stickler for detail, which is good. Now, I want to also add that the perfect is the enemy of the good. So if you don't have all the latest and the greatest, as long as you stick with satisfying the rules, don't let that interfere with you going ahead with telemedicine. You want to be HIPAA compliant and you want to connect. But one of the things that we've seen is the big problem are the patients that can't get on the video. As we audit charts and so forth, we see a lot. Hey, we tried, but they couldn't do it. So, John, how do you handle that when a patient is unable to get on the video?
Well, thankfully, that is extremely rare. As I mentioned, my medical assistants verify that the tech is up to par. So they make sure that the patient can get on. If the patient has any doubts, they verify that the audio and video are working before I even get on. So say, for instance, it doesn't work out perfectly. They can't get audio and video, synchronized audio and video visits working. Then I have to revert to the telephone. Then often for instance, if they can see me but they can't hear me, or vice versa, then I have the ability to send a message through the platform and say, I am going to call you on your phone. And then we go through a less optimal visit. Obviously, you also have the option to offer the patient to see you in person, right? That is still available. Just because the synchronized audio and video doesn't work doesn't mean that everything is lost. You can try to go over whatever it is that you want to go over on a telephone if possible, or you can offer an in-person visit if for whatever reason a fluke happens, that synchronized audio and video just doesn't work out. And I have to 100% agree with you, Ray. Keep it simple. When you first start, you do not need a teleprompter. You do not need a dedicated camera. You don't need 4 monitors like I have in front of me. You don't need dedicated lighting. Just your cell phone. And again, audio matters more. So I'm going to encourage you to use your cell phone and your earbuds or your AirPods or whatever it may be for privacy reasons, and also to make sure that the patients can hear you. I obviously prefer a wired option when it comes to earbuds and microphones, but start with your cell phone, start with earbuds, and have the EHR open alongside the telephone. That's a very easy way to start. You do not need any fancy tech. Or if you have a notebook computer, plug the headset into the notebook computer and then carry out the encounter that way.
All right. Well, thank you, John. Thank you so much for sharing all that information with us and really getting into the details. I think that'll help a lot of our audience look at their own setups and look at how they're doing things, or if they're not doing anything with telehealth, maybe this will encourage them to start looking into that. So really appreciate you sharing your experience and what you've learned over your 4,000, which is an incredible amount of history of telehealth. Thank you for sharing that with everybody. Let's go around and get some final thoughts, and then we'll wrap this episode up. And I'm going to start with Mark, go to Ray, and then finish up with you, John. Mark, final thoughts.
So I guess the main thought here would be this is something that you need to operationalize. You know, planning is key. Execution is key. It is a line of business and a different way of doing things. So take the time, make the plan, and then make sure you're executing your plan.
Ray?
Well, most docs think the way we do things is the correct way to do things, and we always feel like we're doing it the best. But if you're not using telemedicine, get on the bandwagon. It's part of your future, or it should be, and it certainly is a part of the future for patients.
All right. And John?
I'm going to quote Nike and Nike's marketing, just do it. And like Ray said, we like to think that we're doing the best way possible, but always be open to alternatives. And I fully realize that change is difficult. Change is a pain in the butt, and it requires additional energy. But once you start doing it, once you realize how convenient it is for the physician and the patient, you'll never go back. Even if there's no payment for telemedicine, keep in mind that you can offer this as a cash-based basis, cash-based service. I would pay out of my pocket for a telemedicine visit if that means I don't have to leave my office. I don't have to skip seeing patients. Your patients may appreciate the fact that he or she doesn't have to leave work and lose out on pay and still be able to get the care that he or she needs. So as Nike would tell you, just do it.
Awesome. Well, we'll end it there, and I want to remind you that our urology plan, with this documentation, coding, and billing plan, is available, and we'll put that link on our episode page, which is at prsnetwork.com/133. Also, we'll post a link to the Thriving Urology Practice Facebook group, so you can join that. If you just go to the episode page, we'd be happy to include that there. And also, we'll include the name of the telehealth, the doxy.me. So if you didn't get a chance to write that down, but we'll include that as well, that John had mentioned that he uses. All right. With that, we look forward to hearing any comments, and let us know if there are any topics you'd like us to cover. Take us out, John.
Well, first of all, before we I take everyone out, take this episode to the end, I want to say that I have no financial relationship with Doxy.me.
Thank you for doing that.
Just
yes, and we don't either. PRS does not either.
Yeah, just in case. So I like to thank you all for the privilege of your time. Please take care of yourself, take care of each other, and most importantly, happy billing and coding.